morning. It's great to be here. I'm really delighted, and it's exciting to see all the advances that we've made in adipose technology. So we're going to talk about what's happening with fat and what's happening in the adipose world. And these are my disclosures. So I do work with a fair number of companies with different technology. And I think that in order to kind of understand the evolution of where we've come with adipose tissue, it really parallels the evolution of Tulip. And it's been really interesting to see how they were there with us in the very beginning when we started to work with adipose tissue strictly in plastic surgery. And now they're talking to rheumatologists and cardiologists and orthopedic surgeons and all the different applications with adipose tissue. So while we have expanded our scope and have interacted with different specialties in interspecialty collaboration, Tulip has kind of done the same thing, and they've been along with us on the whole ride. So I'm going to start by talking a little bit about the history of Tulip in particular and the evolution, how we started with plastic surgery, and then now how everything is kind of moving into regenerative medicine. I'll give you an update on our current technology and then also the future directions of our industry, of our science and clinical experience, and where we're headed. So in 1987, that was really the beginning of liposuction in the world, and Dr. Illouz from France started with that. And then in 1991, kind of paralleling the development of liposuction, Tulip Medical was kind of right there at the very beginning to say, okay, we need to develop cannulas and we need to develop instrumentation to help these doctors to help their patients. So it started off with Tulip and also in liposuction in general with superficial contouring, and a lot of the stuff that we were doing involved syringe aspiration. And I think that Tulip was really kind of one of the first to recognize that there was less trauma. They were really into the science, having more control over your procedures. And I was lucky enough to go back through the Tulip archives and show you this is the first Tulip brochure from 1992, and there's nothing is so powerful as an idea whose time has come. And I think those words of the founder of John Johnson and Marcel Pilkington, this is what they were really right on top of it from the very beginning. And this was another picture from their catalog from 1992. Showing the handheld aspiration technique and the Johnny Lock and the system that was used for this soft touch for soft tissue type techniques. And this is just another page of the catalog to show you what it looked like back then. And then this is the founder of the company, John Johnson, and creative progress. Those were the two words that he really used, and I think that those are still the kind of the mantra of this company is creativity, progress. It's very, very great words. Great person. At that time, we moved into large volume liposuction. And we realized that we didn't necessarily want to just use a syringe technique, and we needed to, all of a sudden we had aspirators and we had power, so we had to have larger cannulas that weren't connected to syringes, but were actually had handles and were connected to the liposuction apparatus. And so this is just a diagram of the large volume liposuction. This is where we are harvesting the fat and also removing fat for contour procedures below the level of the superficial fascia. And unlike the light touch and the superficial liposuction, this was a little bit deeper and much more volume associated. So of course, during that time, as plastic surgery evolved, so did Tulip evolve, and then they provided us with these great cannulas that had handles that you could actually connect to aspiration pumps, and that was really just a big step in both the specialty of plastic surgery and also with Tulip. Then we started to do fat transfer, and this was in the late 1990s. My chairman at the Texas Medical Center at Baylor went and worked with Sidney Coleman in New York and came back, and we used to joke that in the Texas Medical Center, it didn't matter what you were having done, you were going to have a fat transfer. Toenail clipping, heart surgery, whatever it is, you're going to have a fat transfer. So that was an exciting time. We were really doing a lot in craniofacial, in reconstruction, as well as cosmetic. And Sid Coleman started with fat transfer to the face. And then in 1995, we started doing a lot of fat transfer to the breast. And so we were evolving in that way as well. And we realized that you can't just take a big piece of fat and stick it in somewhere, remove it, cut it out from somewhere, and put it somewhere else. First of all, it would leave a really bad donor site deformity, and secondly, the fat would all die because it can't revascularize. So these adipose grafts, we knew back in the 1970s that this was not the way to go. You can't just cut fat, put it somewhere else, and then hope that it's going to survive. So this handsome guy right here, Dr. Sidney Coleman, is really one of the reason and that we are doing so much fat grafting around the world. And the Coleman technique is known absolutely everywhere. And I think we owe a great deal to Sid for improving our techniques and our clinical outcomes. So Dr. Coleman talks about microfat grafting, and where you're just leaving little droplets of fat in these little tunnels, and instead of a big chunk of fat, you're putting these little droplets, and the concept is that the droplets will revascularize, and that's actually what happens. So in Tulip in 1995, they said, okay, well, we now need to start getting fat grafting instrumentation, not just liposuction, syringe held, and not just power liposuction, but now we have to, the doctors are saying that they want to take the fat and out of the canister and put it somewhere else. This is a brand new concept at that time. So in the 1990s, mid-1990s, this was something that was evolving, and as we evolved as physicians, of course, we worked with Tulip, and they were right with us to say, okay, what do you need? How can we design this? How can we help you? So it's just a great teamwork. And this is a Tulip injection system from way back, and I joke that this looks like something out of Star Wars, but you can see that it's, the technology was progressing rapidly, and as usual, the Tulip was right on the road with us. And so then we started talking about, again, lipoaspiration and injection and versatility. What can we use adipose tissue for? And this is another photograph, another very well thought out piece of marketing material to show how Tulip is versatile, and they're working with us and able to adapt and do different things and use different things to take care of our patients. So and then in the late 1990s, the concept came up, well, how do we coat our cannulas? Once the fat goes through, is it viable on the other side? And there is a lot to be said for how the cannulas are coated on the outside and also the lumen on the inside. And so Tulip, we said we need to have more viability. We need to have better cell counts, and we need to have tissue survive when we put it in another area. And so, of course, they helped us and developed these cell-friendly instruments, which have a very, very nice, smooth inner lumen. And again, this isn't just another a picture from an old brochure from 1999 showing that Tulip was now evolving with us in the self-friendly area. So then in about 2002, 3, 4, 5, we were doing all these fat transfers, and we were breaking all of the injection cannulas. And when we were harvesting or we were injecting, we were torquing the cannulas, and the cannulas were screwed into a syringe with a Luer lock for the fat transfer. And as we were putting the fat in and using the fat transfer technique, we were breaking all of the connection between the syringe and the cannula itself. So once again, what do? We go back to Tulip and we say, okay, well, we're having a problem with this. We're breaking the syringes when we do the fat transfer. So then in 2005, again, evolving with us, Tulip developed the Super Luer Lock. And I can tell you that I don't break any of these anymore, but on the previous, before this, it was a regular occurrence that syringes would break at the Luer connection. So this is another example of the Super Luer Lock, or connector between the cannula and the syringe. And this this almost looks like an antique car museum, but we've evolved quite a bit from that. But these are the Super Luer hubs that we were using, and really not that long ago, in 2005, 6, 7, and around 2008, this is when we started to get into these really fancy Super Luer hubs. Then we found that we were having problems with infections and mycobacterial infections. When you have a tiny cannula and you can't see through it, and there's no hole at the end because it's a blunt tip, you can't really tell if those cannulas are clean. And so we started to have issues with patients getting infections, and we knew that deep down inside it was impossible for us to really verify that those cannulas that were being used over and over again were actually clean. So then what do? We went to Tulip and we said, we're having this problem. We need to think about a way to get around all these issues with patient care. And then, so of course, Tulip developed these disposable instruments. And I think that everything, in the operating room, we used to use drapes and gowns that were sent to the laundry. Now we use all disposable drapes and all disposable gowns. And so, this is an example of Tulip just evolving with us and saying, okay, you need to have an instrument that you can throw away at the end of the case that's not going to cost too much, that's actually going to function very nicely, and most importantly, you're not going to have to worry about a nasty infection in someone's face and that kind of thing. So this is an example. Thankfully, this is not my patient, but this is a patient who came in for fat transfer, and the doctor who did this case actually sent me these pictures to ask me, what I thought happened, and he used a non-disposable, reusable cannula for fat transfer for correction of the jowl. So the patient had the fat transfer, and then the patient came back like 2 weeks later, and there was an issue here. There was something of concern. And then the patient came back, a week later, and it was noted to have a mycobacterial infection in his face. And these are not cured with antibiotics. So you have to debride these patients every day for months. And I thought to myself, I don't want somebody walking around Miami saying, Dr. Miller's my patient and I have this big infection in my face, that kind of thing. So when we talk about disposable instrumentation, and Dr. Coleman has several lectures on fat transfer complications, and many of them are due to the reusable cannulas and very small gauge cannulas. So they're difficult to clean and sterilize. We have had issues with infections, worse outcomes. So this is how we've been lucky to have Tulip right there with us to help us, because as physicians we can't go. We don't have a manufacturing plan in our office. We can't say, okay, well, we're just going to go make disposable cannulas. You need a partner, a team to do this stuff. Everybody has their expertise, and so this was a huge thing. And so this whole new generation of disposable injection cannulas and syringe locks all came out, during that time, and it's been a very, very big plus for us and for our patients. Useful accessories. I know this sounds silly, but when we do lipoaspiration, the nurses do not have a test tube rack or something that they can put the 60 cc syringes into. So invariably, they would put them in the corner, get a couple instruments, prop up the syringes so we could let the tumescent fluid settle to the bottom, And almost every time they would get knocked over, and then we had to put them back upright again and wait for the tumescent fluid to go to the bottom. So we said, we need a rack, that test tube rack that can fit a 60 cc syringe, because we have 6 of them or 8 of them that we're going to use for harvesting, and we need to have them stay upright and not fall over and then have to put them upright again. So I know it sounds silly, but this little rack here has made a huge difference in our efficiency during these procedures. So again, now we're into the 2010, 2012, and we realize that there are stem cells in adipose tissue that can be used for other specialties. So musculoskeletal doctors, rheumatologists, interventional pain doctors, physical medicine, rehabilitation doctors, dentists, maxillofacial surgeons, all of a sudden they see a need for adipose tissue. And a lot of it has to do with regenerative medicine, dermatology as well. So we had to find new instruments where we could harvest stem cells, concentrated clusters of adipose tissue with stem cells for these orthopedic procedures, for these rheumatology procedures, for these dermatology procedures. So I was lucky to, at this time, already had developed a nice relationship with Tulip. We had collaborated on some things, and I said, I'd like to design a harvester that can be used one for orthopedics and rheumatology, one for dermatology, and also one for plastic surgery. So I went through probably, 10, 12 prototypes, and I have to thank, Mark Pilkington and Debbie and Marcel for being patient, because I know that as an obsessive compulsive doctor, we can be a little bit of a pain in the butt, so we had to design it and modify it again. But we got to the point where we developed this harvester that really works very well, and the different gauges of this harvester work well for different applications. And so now we are taking, as we are expanding our adipose world and moving into the musculoskeletal market and into the dermatology specialty, we need to have cannulas that can harvest adipose tissue for their specific indications, not for ours, but what is the best particle size for somebody who's going to be doing an orthopedic procedure or a maxillofacial procedure or a dental procedure. So you have to have different tools for these different things, and the port size and the configuration is something that is really important. At first I designed with these really big holes, ports, and then the fat would come through with these gigantic chunks, and I was like, this is not very good at all. So then I went the other way and I said, let me put tiny little holes, and then I ended up sucking out all the oil and no fat and no stem cells. And so we had to kind of really modify this, and in creating kind of a spiral configuration with sharp edges on these disposable cannulas has been really, it's really helped us with our outcomes and even with just the time of the procedure and the patient care in general. And then there was this one last dinosaur, which was, I need to show a picture of this. I don't have it, but it's a blue aluminum syringe lock that was made by Tulip. And we said, okay, we have disposable everything, but we have this metal reusable syringe lock, this blue aluminum thing. And I suggested that we send that to a museum, because I thought, it was a little bit, old-fashioned looking compared to the rest of the stuff that was so nice and disposable. So then we went back and we developed a 60 cc snap for these handheld aspiration procedures. And we went through quite a few prototypes of that, and I remember actually that Mark Pilkington handed me one in a restaurant here in San Diego, and I pushed down on it, and I broke the flange immediately, and I was like, oh, maybe we should, so we worked together to improve this prototype, and then we eventually created this and put this into production. But the fascinating thing is that even after this is in production and we're using it, I'm still getting calls from Tulip saying, do you think maybe we should make the flange a little bigger, or we should, do something to make the engagement of the lock on the stem or the plunger? Should we, And so it was fascinating to me because I see medical instrumentation companies that develop something, and then that's it. See you later. This is it. This is how it is, and this is our design, and that's it. But it's so interesting to see how, Tulip in particular would call and say, let's make it better. Let's try to even make it better than it is right now, which is very unique, I think, and something that we really don't see that much in the industry. So then we were using, then Dr. Tonard and Dr. Verpel brought onto the scene Nanofat, and we said, okay, well, we need to emulsify fat to get it into the nano stage like they taught us. So, of course, we talked to Tulip, and they say, okay, we're going to make disposable 2.4 Luer-to-Luer connectors, and we're also going to make a 1.4 millimeter, and we're going to make a 1.2 millimeter. So again, everything that we're doing for these procedures, we're getting a lot of assistance from our partners at Tulip. And this particular technique is not just for nanofat, but we're also using this for orthopedic procedures. So we're really killing the fat cells with the Venturi effect of the Luer-to-Luer transfer, and then we're either creating nanofat for plastic surgery or dermatology applications or other things as well. So this is another disposable piece, and I can tell you that in the 1990s in the Texas Medical Center, we would go to Williams and Sonoma and buy like a big bowl and put it in the autoclave, and then the fat would be in the bowl, and then we would suck the fat out of the bowl with the syringe. So when we got to to the point where we had Luer-to-Luer transfers, it was less messy. There was less fat all over the floor, and it's a nice closed system for this. So we're really lucky to have two very special people here who are really the creators of Nanofat. And I remember hearing the stories back in the day about the cheesecloth and the very, very beginnings of Nanofat. And we're super lucky to have both of them here because usually they're so busy and there's so many people around the world that want them to come and speak that it's either you have Alex or you have Patrick, but you don't have both of them here at the same time. So thank you guys very much and really appreciate all your contributions. I'll probably mention that at least 100 more times before the end. So the nanofat indications for, if we have thin skin, minimal subdermal tissue, particularly in the tear trough area, we needed to do intradermal injections, where we weren't really filling, but we were using nanofat technology. So we said to Tulip, we need to have a good transfer. Actually, I didn't say this. Patrick and Alex said this to Marcel and Mark and Debbie, that we needed to have a nanofat transfer system where we could create nanofat with a serial Luer-to-Luer transfers and then a screen or a nanofat to transfer system. So this was developed again by Tulip, and I think at the request of Dr. Tonard and Dr. Verpel, and this helped us to produce nanofat in a way where we could then take that screen and we could dispose of it and still have that disposable technology. And now I need to update this a little bit, but now the nanofat transfer system is also disposable, so that's another advance. And I'm going to talk a lot about nanofat and microfat throughout my lectures, but this is just an example. The light colored, the really milky one is emulsified fat that we're going to produce nanofat, and then the more yellow one is or the darker one is just the microfat. So you can see, and what we did was we actually produced nanofat, and then we spun it down, and we also spun down in comparison a microfat sample, and you can see that the nanofat has much, much more oil and very, very little adipose tissue. And I think that was highlighted very well by an article that was published by Dr. Tonard and Dr. Verpel, which showed that there really isn't much fat in nanofat. It's more the regenerative soup or all of the cytokines from the stem cells themselves. But you see, if you spin down nanofat just like their paper shows, you don't really have much fat in Nanofat, but you have lots of good stuff in there. So this is just showing the consistency of Nanofat versus microfat. And Nanofat really should drip out like a liquid. So you can inject it in through a syringe in a very small gauge cannula. And then this is just from Drs. Ternard and Verpale, their article showing the needle injection of the Nanofat and their amazing results with discoloration under the skin and lipstick lines around the mouth, and then also in the décolleté and the chest area. So future directions, where will we go next? I'm not sure, but wherever we go, we'll probably, Tulip will be right next to us as usual. I think multi-specialty collaboration. In Miami, I work with a lot of orthopedic surgeons and dermatologists and dentists and people that are really interested in utilizing adipose tissue for regenerative medicine technology, and I think that the multi-specialty collaboration is really important. And then looking more scientifically and figuring out what it is about this adipose tissue that's so special. We need to kind of look into the mechanism of action. And then also, physician training. I think this is an important thing, and I think Tulip this is a great example of cadaver labs and interaction with faculty and lunch and learn and those kind of things. So I think it's really, really nice to be able to share this with other doctors. Tulip I don't think this should be a future direction of Tulip is integrity and quality. I think it's been there the whole time. So that's a past direction, a current direction, and a future direction. So, and then also international collaboration. And I would say that I do a lot of work in Asia, and I would say that Tulip is really the first American brand or company that has come to China and brought their technology to a world where they're very, very behind in technology, but very interested to catch up. And if you could play this video, this is just some clips of some meetings in China where you can see that Tulip is blazing a new trail now as more American and Western and European doctors are moving into educate doctors in Asia and China. Tulip is right there with us, so we can have that instrumentation there and be able to advance the treatment. So this is just these are some clips from, this is a particular meeting is from Shanghai, and we're really, really excited. If we go to Asia and mainland China in particular, they don't have any advanced technology at all. So we can't do these procedures there unless we have the instrumentation that we need. So it's nice, again, to have a partner who's with us and can help us blaze the trail, because we really can't do it by ourselves. We need the technology to be working on these patients. And you can see these are this kind of extravagant meetings in China. While they're quite extravagant, the operating rooms are 100 years behind. And so it's nice to go to different regions of China and say, we have our Tulip instrumentation here, and they know that they have access to that and they can get that. This is a team that I work with in Hangzhou, China. And this is a ridiculous billboard in the middle of its square which says, Dr. Miller, big Hollywood movie star. And I said, that is absolutely not true. And they said, no, it's true. And I said, it's not true. But anyway, but it's nice to, at that time, I think I still had some Tulip cannulas in my bag in the car. So this is just an example of how they're helping us to blaze the trails and make friends with other doctors in different parts of the world. So thank you very much for your attention. I appreciate it.